So hey, we're doing a break. Somebody's asking about ultrasound, and then when you guys do your ultrasound, your ER lab, you'll do all this. Like you'll get to actually like do the EDT, right? The incompressible knot. Just keep in mind that the skills you learn here is good, and then you're gonna go into phase 2, and then you're really gonna hone your skills. A lot of the things we do, like everything else in life, right? It's perishable skills. So when you actually get out there, right, if you're just working a primary care clinic and you never drop an ultrasound on a patient, right, and then you get that somewhere where you're expected to and you haven't done it in a while, it's not fun. So find ways to keep your skills set up. If you're at a location that has an ER, go down there every once in a while. Or grab your corpsman in clinic or your medicine clinic. At the end of the clinic, hey, lay down, let me do a fast exam on you. Right? Keep that skill set up. Right? ER rotations. Like I did my ER rotation. Like every healthy, like active duty Marine and Navy dude that came in, they got an ultrasound, right? Whether they needed it or not. Because you gotta get that muscle memory. All right, final one, transfusion medicine. I can't stand behind. I can't do it. All right, at least I'm standing behind the podium. Yes. All right. Usual objectives. Again, pay attention to these. Kind of help you as far as, hey, this is sort of testable area versus not. All right. Blood products. Whole blood, packed RBCs, FFP, all right. Cryo, platelets, freeze-dried plasma. Anybody ever use the freeze-dried plasma? Yeah, I figured it. All right. Because the SF dudes always get everything ahead of it. So when I got to the teams, we had the freeze-dried plasma. And at the time, it was a French company that was making it, and they were putting them in glass bottles.
It still is.
Is it? They haven't gone to the plastic thing yet? They haven't figured that out?
Now it's still glass bottles. Like you have to have your whole team sign a waiver saying that saying they're willing to get it, and if they get it, they can't give blood for like X number of years once they get back to the States, and it's a whole process. It's not FDA approved yet.
And it's not user-friendly, right? It comes in 2 bottles. One has the freeze-dried plasma, the other one has a diluent. And when you're gonna do it, you have to reconstitute it. And the bottle thing and the vacuum suction on there works half the time, right? If you're a dude that's jumping in, all right, on target, and you got these glass bottles in your bag, right? Not really user-friendly. Most of the dudes anyway carry whole blood, right? Golden hour boxes or jump in with whole blood. All right, the transfusions. Critical, yes, sure, you guys know this, right? The key for us is, hey, when do I need to transfuse somebody? What products am I gonna transfuse? Is this a whole blood? Is this a PRBC? Do I need platelets? Do I need cryo? Right, and then the big part of this lecture is, hey, the transfusion reactions. Anything we do in medicine, right, there is a potential adverse side effect. We should know how to handle that adverse side effect when it happens. Right? And that's kind of what this is here, we're going to talk about with the transfusions. If things don't go accordingly, what should I do? All right. And then why do we do transfusions in the first place? All right. Why do we need blood? Right. Talk about anemia, right? Lack of hemoglobin, lack of oxygen carrying capacity. Am I trying to restore that? Sure. Fresh whole blood increases your oxygen carrying capacity, right? Trauma, platelets, the whole 9 yards. Kind of the standard in medicine now. A lot of civilian EMS systems will carry whole blood now. I think San Antonio's actually carry whole blood. Packed RBCs, anemia, acute blood loss. 1 unit of PRBCs will raise your hemoglobin 1 point. And you see the volume there associated with packed RBCs. This, don't try to memorize this, right? This is just to give it an idea that, hey, when does somebody need a transfusion? Everybody that's anemic needs a transfusion. Yes? No, right? Are they symptomatic? Right, then maybe they need a transfusion. And you have all these different criteria they come up with for who actually should be transfused. But usually if I'm getting down into that 6 range, yeah, I probably need a transfusion. All right, there it is. More clinical pathways to figure out who does or who doesn't need a transfusion. Platelets. Why would we give somebody platelets? They're not hard, right? We know what the function of platelets, right? Help with clotting. So somebody that's low on platelets might need platelets. If they're what? Low and symptomatic, right? So that's the key, right? And we talked about some of these disorders where, hey, I'll watch that platelet get down there, right? 50,000. But are they symptomatic or not? General rule, right? Yep, 6 units, pool platelets for each unit. Got it. Increase platelet by about 30,000. Prophylactic, yeah. So any of those bleeding disorders, right? Do they can they benefit from platelet transfusion? FFP. What do I have in FFP? All your coagulation. It's just your plasma, right? So I got all my coagulation factors. DIC. What's DIC? What's going on in DIC? Consumption coagulopathy. I've used up all my clotting factors. I've used up all my platelets. Right? If I've used up all my clotting factors, what's going to help me replace those clotting factors? FFP potentially, right? Liver failure, we know this, we've beaten this to death, right? Liver not producing your clotting factors. Cryo. There's everything in the cryo, your fibrinogen. Factor 8, factor 9. What diseases are associated with the deficiency of factor 8 and factor 9? Hemophilia, right? Indication for fibrinogen replacement, sure. Any of those disorders, got it. All right. Indications for transfusion. Who do I need to transfuse? Symptomatic anemia. So we know their hemoglobin's 10, they're anemic, but they're otherwise doing okay. But do they really need a transfusion? Probably not. Their hemoglobin is 8, and just getting out of bed, they're exhausted. Do they need a transfusion? Yeah, they probably need something, right? Acute blood loss, we got it. And then some of these conditions we talked about, ITP, TTP, hemolytic urine syndrome, all these where your platelets are getting eaten up. And then our deficiencies, hemophilia A and B, as you said, and potential von Willebrand's. What's the problem setting the von Willebrand's? You need a von Willebrand's to find that platelet. Right? You need a von Willebrand's to stabilize which factor? 8. There it is. Again, another matrix for kind of deciding. Based on their hemoglobin levels, should they be transfused or not? All right. ABO compatibility. Everybody know their blood type? I hope that's a yes. Everybody confirm their blood type? Yeah. They had a study one time that showed I think it was 25% of dog tags were actually wrong. Right. All right, ABO, this I'm going to take it for granted that you guys know this. Am I wrong? All right, everybody knows, right? A, B, O, or AB, and then your RH, right? Are you positive? Are you A positive? Are you A negative, O negative? Whatever. Good. The 3 antigens, the blood types that's associated with them. Right, so the key here for us, right, these antigens, the ABO antigens, are extremely reactive, right, strongly hemolytic. So if you give somebody the wrong blood type, the wrong blood, something that's incompatible with who or what they are, you're gonna have a problem. And you're gonna figure that out real early in the transfusion. It's gonna show itself. All right, and then the R8 system, right, and we'll talk about hydrops fetalis, or excuse me, erythroblastalis fetalis. Good, and there it is, right? So you can kind of figure out who gets what based on that. What's your universal donor? Who's your universal recipient? So now let's talk about some of the badness. The hemolytic reactions, acute hemolytic reaction. This is ABO incompatibility. Presents fever, chills, hypotension, back pain. Why the back pain? Kidney's taking a hit, right, from the hemoglobinuria. This is an extremely hemolytic reaction. Occurs within the first 24 hours. And so by definition, it occurs within the first 24 hours. Usually this occurs like within the first hour of the freaking transfusion. All right, so you realize that they got an acute hemolytic process going on. You got the wrong blood. What's the first thing you want to do?
Stop it.
Stop it, all right? And then IV fluids and diuresis. Why the diuresis? All right, trying to preserve your kidneys. Again, this is something that's probably going to show itself real early in the transfusion. Acute hemolytic. All right. Delayed hemolytic transfusion reaction. Minor incompatibility. So these are other antigens and antibodies, non-ABO, right? Against the donor cells, anemia, fever, jaundice. Key for this is occurs when? More than 24 hours out. All right, non-hemolytic, an allergic reaction. So we'll talk about this a little bit too. So allergic reaction to the plasma proteins, like a lot of the allergies, urticaria, pruritus, flushing. See this here, angioedema, wheeze, and stridor. Now I'm a little bit more concerned, right? Because, all right, it itches, I'm not too worried, right? If they're having stridor, if they're showing signs of anaphylaxis, and this can vary, and depending on which textbook you decide to pick up, you'll see allergic as, oh, it's just urticaria, it's just pruritus, just give them some antihistamine, and Charlie might continue on. But does it cross over? Does it get so severe that it's actually anaphylaxis? So again, right, stop the transfusion. Antihistamine, sure, to treat the urticaria and the pruritus. Steroids. Right? If I've crossed over into anaphylaxis, then epi, right? You're going to manage the anaphylaxis. Can continue transfusion and follow antihistamine if it's just urticaria. So that's textbook. All right. Me personally, I'm scared out of my mind at this stage, right? I want them to have nothing to do with this. Right? If I'm in Bright Lights, big city hospital someplace, and I got 20 million people watching this patient, maybe. If I'm downrange, I got no time to deal with this stuff. I'm not even taking a chance. All right? I'm treating them. I'm getting a different unit, whatever. Febrile non-hemolytic. Again, it's immune reaction to the donor leukocytes, presents with fever, right? Febrile. Again, kind of we talked about with the other diseases, or let's go back to the name. It's in the name if you're having trouble. Febrile non-hemolytic. Febrile fever, no hemolysis. That should help you out when you're working through a problem set. Occurs within the 4 hours of transfusion. Yes, and I want to stop the transfusion. How do I treat a fever? Antipyretics. And then this note here, diagnosis of exclusion. So if this is what I'm dealing with, I think this is what I'm dealing with, I gotta make sure it's not something worse. Make sure it's not something that's gonna kill this patient, quick and hurry, right? trolley. Again, another non-hemolytic process. Transfusion-related acute lung injury. Immune reaction to donor antibodies, and they present with a respiratory distress. Fever, chills, respiratory distress. And what's happening here? You have an immune response within the lungs. So you're getting this inflammation in the lung. Stop the transfusion. Supportive care. If it's severe enough, right, do they need mechanical ventilation? We'll talk about this in relation to taco here. Yep, good. So taco, right? Transfusion associated with circulatory overload. So these tend to occur in patients that take a massive amount of blood, a massive amount of fluid in a very short period of time. Rapid transfusion, large volumes, pulmonary edema, wheezing, wails. During the first 24 hours, again, I'm overloading this patient. Stop the transfusion, diuretics, get some of that fluid off. Had a ranger that got hit. I was listening on the call when they did this kid's after action report. This kid got hit in country, got taken care of, got blood on the scene, got blood at the roll one, flew to Germany, got blood back to the States, had over 100 units by the time this kid. 100 units. Right? So and survived, and, carried on with his life after the fact.
So after large-scale traumas, you're going to be administering a decent amount of blood products. How commonly does this happen, and how high should our expectation be that the case is very likely?
So for any badness, right? So the way I practice medicine is I worry about the bad stuff. And I'm always worried about the bad stuff till I prove otherwise. So large-scale traumas, are you stateside or are you downrange, right? Because what you have resource to you is a completely different, right? Hospital, big city, I got ICU nurses, teams, docs, everything's gonna go manage that patient at the end of the day, right? Downrange, what's your hold time for this patient? And again, I come from the era of 15 minutes, I could move a patient from X to back to my roll one. Do whatever I needed to do, and then I could get him moved on. If I'm in Afghanistan, I could get that kid moved on to Bagram once I got him stabilized. The war that you guys are looking at, you're looking at hold times of days. What's the likelihood of something like a trolley developing, a taco developing, if you're infusing?
What are we going to define as like a large one? At one point, are we saying like, hey, is it like 10 units? Is it 50 units? Like, I don't have a frame of reference.
Yeah, so they have their definitions for like a massive transfusion, I think like 10 units in whatever hours. There's actually like a definition for massive transfusion you'll talk about. But again, right, so you have to think about, and we can play the game, right? Here's the rules of the road, and then reality sets in. Right? Who's my patient? How bad were they to begin with? What were their comorbidities? Right? Is this a local, like a kid that they roll into your friggin' BAS, right, who got blown up? An ability to handle a transfusion is a little bit more challenged if you're pumping a lot of blood into them sometimes. So, key for you guys, right, you're gonna transfuse, and then you're gonna look at vital signs, right? You're always monitoring. Right, so that's the key. Anything we do in medicine, what do we do after the fact? Any intervention, you reassess. Right? Is my patient now moving in the right direction? Right? It's one thing to make an intervention, but if you never reassess, you don't know that intervention is effective. Right? Have I gotten their blood pressure up enough that now I can worry about something else? Have I corrected that anemia enough that now I can worry about something else? Right? And unfortunately, or fortunately, depending on where you're at, you're doing all of this multiple times, and then sometimes you're doing this on multiple patients. Right? So I'm the doc in the friggin' BAS in Afghanistan. I got 3 corpsmen. Right, so I'm managing all 3 patients, and I'm throwing in a chest tube, and my E5 is over here throwing in a chest tube on the other side. Right? I still gotta know what's going on in bed 1 and bed 3. Right. You have to be able to kind of do a lot of stuff on the fly, but again, part of what you bring up is important, right? In the sense of the challenges that I had is gonna be a lot different than the challenges that you guys have, because we are looking at longer and longer hold times. Right? Do you have that critical care piece that you can hang on to a patient? Because vent management even sucks, right? If you had the tube a patient, and now you gotta manage that, because they have these little save 1, save 2 vents, they're not great, right? And now you gotta work on this, and it's you and whoever is downrange, and you may not have a whole team of whatevers. Right? And now you're stuck with a patient, now I gotta do vent management on this patient.
The result that they came out with is actually pretty decent.
Yeah, yeah.
It's of course not a portable one, but it's a lot better than safes.
I tell you, right, so I'm looking at this problem set, and I'm thinking of you guys, right? Because I had whole surgical teams. I took a team on a boat one time, right? And I'm like, hey, we're gonna be transiting from here to here, and I may need you to hold a patient because I'm not gonna be able to fly this patient off. I need you to be able to hold this patient for the next 5 days, right? And this is a full-blown surgical team, right, who trains for this stuff, and they're like, no, I can't hold a patient for 5 days. Again, this is what's gonna be expected of us in this next conflict, right? But I got surgical teams looking at me sideways when I'm saying, hey, this is what I need you to do. So again, we gotta train for this. All right, taco, so they're fluid overloaded, all right, versus trolley where the lung is taking a hit because of some sort of an immune reaction in the lung. Diuretics, stop transfusion, yep. And then, hey, how am I gonna manage this? Right, pulmonary edema, rails, do they need O2? Transfusion, transmitted infections. Like, this is a weird one. All right, transmission of infectious agents, sure. So is it the bacterial infection that's showing itself, right? So they develop the fevers, rigors, tachycardia. And you can see this can happen quick, which is what was really surprising to me, right? Within 30 minutes sometimes, it can start showing signs. Stop the transfusion, septic shock. This is an infectious process, so broad spectrum antibiotics. And then culture, so you're gonna culture everything. Because you don't know what the causative agent might be. And then, yep. So more of the same, bacterial specific, gram-negative, gram-positive with platelet transfusions. Take your pick, whole host of potential causative agents there. And then the viral stuff that we've always kind of, hepatitis, Hep C. Is this gonna show itself to you guys, like intuitively, while you're transfusing somebody? Are you gonna, yeah, man, I think I just gave that person Hep C. No, right? This is way after the fact kind of thing. All right, other potential. Hypocalcemia, yeah. So, packed RBCs, all these, they have certain anticoagulants, certain preservatives that's built into them, right? So do they end up with some metabolic reaction as a result of some of this stuff? Hyperkalemia, bunch of packed RBCs, bunch of red cells. Do some of them lyse because they've been in storage for however long. And then iron overload. Occurs when transfusions are given for anemia not caused by iron deficiency. So somebody give me an example. Like when might I be transfusing somebody?
Thalassemia?
Thalassemia. Winner, chicken dinner, that's a big one, right? We talked a little bit about with thalassemia B patients. They end up iron overloaded because they require frequent transfusions sometimes. Therapeutic approach. All right, so I'm giving this patient a transfusion. I'm thinking, uh-oh, I'm starting to see blood pouring out of their IV lines, blood pouring out of their catheter. All right. What am I thinking about? So a bunch of things come to mind, right? But again, I just initiated this transfusion and I got all this stuff going on. So I gotta take a step back and kind of figure out what's going on. If I at all associate this with a transfusion, then I need to stop my transfusion. And then the usual assess, monitor your patients. Yeah, if you're someplace like, where big, bright lights, big city, you got a hospital, sure, talk to your blood bank. Supportive care. Do they need fluids because I need to protect their kidneys? Do I need to diurese them? All right. Do they need vent support? Do I now need to intubate this patient and take their airway, right, to protect them? Sure, blood test DAT after the fact, and yeah, consulted after the fact. Nobody cares, right? So key for you, right? I'm worried about the transfusion causing the problem. I need to stop my transfusion, I reassess, and then manage whatever the problem set that was created, right? If it's an allergic problem set, how are you gonna manage an simple urticaria reaction? With antihistamines, right? Now, let's say now they've trafficked from just anaphylaxis into angioedema, into anaphylaxis. You're gonna have to go down that pathway. All right. Erythral status fatalis. All right. So hey, we talked about the ABO and we talked about RH. So this can happen. You see this where the problem set is a woman who is RH negative, right, but the fetus is RH positive. And then if there is some crossing of blood, right, from that RH positive fetus into the mother's circulation, the mother is going to produce antibodies against that RH antigen. So usually, if that happens on a first pregnancy, everything is fine, but now that mother is sensitized, she now has anti-D, anti-RH antigen antibodies floating in her system. So if she gets pregnant again, she's RH positive, she now has antibodies against that. And that's what we're talking about here. So RH incompatibility, yes, potential for ABO incompatibility, we're going to talk about that. But what we're focused on here is RH incompatibility. Pregnant person, RH negative, fetus, RH positive. You guys know the Clara or Bet-P test? Did you guys talk about that in the lab? All right, potential causes, the placenta detaching from the wall, bleeding during pregnancy, right? So some sort of traumatic whatever would cause that. And a lot of times, as a former lab tech, I'm working in the lab, right? And you get a pregnant woman who was in an MVA. No big deal, seatbelt fine, but the docs in the ER say, hey, I'm worried. So they'll order a test called a Clara Bet-P. And the Clara Bet-P will tell you how much of that fetal blood ended up in the mother's circulation. How do we treat this? Program. All right, clinical manifestations, anemia, jaundice, sure. You have an antibody reaction causing hemolysis. You guys know what hemolysis looks like, right? Jaundice and so forth. Blood tests, yes. Ultrasound, assess size, yes. Sure. Program. So in the instance of a RH negative mom, right, medication can be given 28 weeks and then again at 72 hours after. What's the purpose of giving it 72 hours after delivery? Right, you're preventing any potential sensitization so this doesn't occur with her next pregnancy. Yeah. Good. Oh, there it is in picture form. Friggin' dad causing the problem again, right? So RH positive dad. Kid can end up being RH positive because the mom, does any of that blood end up in the mom's circulation that would sensitize her and cause her to produce antibodies against the Rh positive antigen. Early diagnosis, prevention, program, it's usually a non-issue, let's be honest, right? If we know mom's Rh negative, she's gonna get her program early on and get her program after the fact. Any questions? Oh. All right, so 2 lectures down today, quick and dirty, right? So next, class leader, let me know when you guys want, if like the next lecture block, we just wanna do the